Thank you for having me, and great to be here in person. I'm going to address this very large topic in 25 minutes, so I'm sorry if I'm going to rush through some of this. I don't have any disclosures. The objectives would be to discuss some new insights on existing treatment, followed by some newly approved therapy, and finally highlighting some new therapies that are in the pipeline. So needless to say, we all know that the drug development has really taken off in a big way in the last 20 years. After 1955, the next approval was in 2011 with belimumab, followed by belimumab in lupus nephritis, and in the last year we've seen 2 drugs be approved, anifrolumab and voclosporin. So before I really dive into the lecture, I just wanted to start with a question. This is on 40-year-old female lupus patient who's had a 15-year history of very active disease and previously was treated with mycophenolate and hydroxychloroquine. She's done very well for the past 2 years with low lupus disease activity, and you've maintained her on hydroxychloroquine. So what would you do next in terms of treatment now that she's been stable for 2 years? Would you reduce the dose to 5 milligram per kilogram as recommended, stop hydroxychloroquine, continue at the same dose, or check the level to see if she's adherent? I was asked to wait to 100, so I hope we get to 100 quickly. Okay. Maybe 75. Okay. All right. Okay, so most people would reduce, and I guess some would continue, and nobody would stop. That's good. All right. So there's no right answer here, really, other than probably stopping the drug, I guess. And that data really came from this abstract that was presented at the ACR, which looked at lupus disease flare risk in patients who had either discontinued or reduced hydroxychloroquine dose versus maintaining it. This was from the SLIC cohort. About 1,500 patients were followed over 33 sites since 1999. And the reason for reducing the hydroxychloroquine dose in these patients in about 50% was because they were in a low disease activity state, and about 5% because of the recommended reduction in dose to 5 milligram per kilogram. And what we see is that the patients who did reduce the dose had a higher flare rate than the ones who were maintained, including those who were in clinical remission or had low disease activity. When they looked at this in terms of discontinuation of the drug, which again in 4% of patients was because of retinal toxicity, and about 15% of patients who were in clinical remission, again we see that regardless of whether they were in remission or not, whether they were in low disease activity or not, the flare rates were higher in patients who discontinued hydroxychloroquine. The rate of retinal toxicity was about 4% in this cohort. But then moving on to, if you do maintain the drug, what is the real risk of retinal toxicity and who needs careful monitoring? And that was addressed in this abstract. What's happening? This abstract that looked at about 5,000 patients who were followed, who had been on hydroxychloroquine for more than 5 years. And what they found was that the risk doubled with every 5 years of use and was increased in a dose-response manner in patients who had higher dosing per absolute or ideal body weight. And other than these 2 factors, some of the independent risk factors for hydroxychloroquine retinal toxicity in this cohort was chronic kidney disease and Asian race. particularly with chronic kidney disease. The risk was doubled in patients who had CKD and tripled with respect to severe or moderately severe retinopathy. The incidence was about 3.2% in this cohort. All right, so moving on to question number 2. 28-year-old, recently married, newly diagnosed patient who was quite active. And what is your drug of choice in this group? I think this didn't make it out correctly, but hydroxychloroquine would be for all groups, and then the question is, would you add belimumab, mycophenolate, or anifrolumab? Yes, I had changed the slides. I don't know why the new one didn't make it through, because I took hydroxychloroquine off the choice. So the choice is between belimumab, mycophenolate, and anifrolumab. What would be the second drug you would add? Okay. So belimumab wins, I guess. Somebody saw my next slide, but so belimumab, I just wanted to highlight some of the studies that have been done in belimumab after its approval in 2011. Various different trials looking at long-term efficacy data, looking at different subpopulation, be it pediatric, Asian, or Black population, as well as lupus nephritis, so you can read them in your own time. So just highlighting some of the updates that happened in 2021. The first one is the belimumab summary of lupus efficacy, which pooled data from 5 randomized controlled trials looking at risk of severe flares. And what they reported is that in patients who were on belimumab, the risk of severe flare was 14% versus that of 22% in patients who were on placebo, yielding a risk reduction of about 39% with respect to severe flares in patients on belimumab. And also patients who were on belimumab, in fact, had a higher rate of glucocorticoid reduction and a less of an increase in glucocorticoids in this population. There was some question about sequential therapy in belimumab and Rituxan, and these 2 separate studies highlight that approach. Beat SLE was 52 patients who were randomized after getting rituximab to either getting belimumab or placebo. 26 patients got belimumab at about 4 to 8 weeks after rituximab, and this was intravenous belimumab, and 26 patients got placebo. And 32 patients completed this trial. So the primary endpoint of this trial was really reduction in the double-strand DNA level at week 52, which the trial did achieve. But they also reported a risk of a decrease in the risk of severe flare in the belimumab rituximab group compared to placebo. There was no serious infection risk in the group that received both drugs versus single drug. Moving on to Bliss Believe, which was presented last ACR, the approach was slightly different. These patients now were on belimumab. There were 292 patients, and half the patients were then randomized to get rituximab at about 4 to 6 weeks. This was subcutaneous belimumab followed by rituximab 2 doses. And the other half then got divided to either getting sham Rituxan or placebo versus just belimumab standard of care, and the groups were followed for 52 weeks. The next 52 weeks were an observation phase. The trial went on for 104 weeks. The trial did not meet its primary efficacy endpoint, which was quite stringent because they were looking at SLEDAI-2K of less than or equal to 2 without other immunosuppressants and a pretty low steroid dose. But what they did report is that average duration of disease control and a reduction of SLEDAI-2K from baseline to week 104 favored the rituximab belimumab group. And they reported more serious infections with the combination therapy. So I guess the question that's come up is it the sequence of when you give the drug, whether it is intravenous versus subcutaneous, whether it is the criteria, what led to the difference that we see here? Finally, with respect to belimumab, I do want to point out some pregnancy data. This is something that is really needed. This is a population in need in lupus, and we have very little to treat pregnant patients. This was data that came out of Taiwan. 13 patients with 13 pregnancies were evaluated in a retrospective manner. So the median age group of these patients was about 38 years, and they had 46% of them had prior pregnancy loss. So this was a fairly high-risk group of patients that were evaluated in this cohort. Most patients were on aspirin, hydroxychloroquine, and glucocorticoids, and azathioprine was the drug of choice in this group. When we look at outcomes, there were 2 miscarriages in this population. Both were in patients who had a prior miscarriage. Term pregnancies were 3, and about 60% of the patients had preterm delivery. With respect to fetal outcomes, there were no fetal anomalies in this group, but there was about 40% incidence of respiratory distress, which did resolve. One case of lympholitis was noted, and that was in a patient who had received 2 doses in the 3rd trimester of belimumab. In terms of obstetric complications, mostly it was rupture of membranes and antepartum hemorrhage. Moving on to the 3rd question of the talk, 30-year-old lupus patients, previously well-controlled disease on hydroxychloroquine and belimumab, now has rash and arthritis. She's intolerant of mycophenolate and azathioprine. You've started her on steroids and are considering switching to anifrolumab. What will you do before that? That's the right answer. So that was one of the key take-home points from the anifrolumab trial, was the high incidence of herpes zoster that was seen with the drug. To give a little bit of background on the history of interferons in lupus, it was first identified by Lindenman and Isaacs in 1957, when they were looking for this phenomenon called viral interference, where one virus inhibits the replication of another virus. In 1979, it was first discovered that there is high levels of interferon in patients with lupus, and following some of the early successes of interferon therapy in malignancy, some of the early drugs with targeting interferon, such as Teletaciocept and Litifilimab, were studied. The drug didn't do all that well, and then the development was discontinued around 2015. Anifrolumab was a step up in terms of interferon therapy because it targeted the type 1 interferon receptor, and thus suppressed all 5 types of interferon, as opposed to the other drugs that were particularly interferon alpha inhibitors. The approval of anifrolumab really came from these 2 pivotal trials, the Tulip 1 and Tulip 2. Tulip-1 did not meet its primary endpoint, the SRI response, but did meet some of the key secondary endpoints of BICLA, steroid taper, class C, and joint scores. Interestingly, what was noted after the trial was analyzed was that some of the patients who had been labeled as non-responders because they had been on some form of NSAID, either new or increased dose after randomization, the trial was reanalyzed by using an amended rule to allow these patients to be in the analysis group. And so Tulip-1A is really the results from the amended analyses. And while SRI response was still not met, there were better responses with respect to BICLA, steroid taper, and class C. Learning from the Tulip-1 data, the primary endpoint of Tulip-2 was changed to BICLA, and I guess they didn't need to do that because Tulip-2 had a pretty successful data on both SRI-4 and BICLA, as well as steroid taper and class C. While joint scores and flares were not significant, there was a numerically favorable outcome with these two scores as well. Just to point out here, this is a busy slide, but what I really wanted to point out was these data in red and yellow, and then the teal blue. With respect to BICLA, in the top right section, you'll see that when you divide the patients up by interferon high versus interferon low signature, the response rate really across the board with Ibertamide, which is in red, is about in the mid-40s, which is 45 to 46%. And that is true even in Tulip-1 as well as Tulip-2. But what really changes in terms of response is the placebo rate that we see is about 27% in the high, but goes up to almost 40% in the low, and also jumps by about 5% in Tulip-2. And that's what really leads to these differences that we are seeing in the effect sizes across these groups. While it's not as dramatic for the SRI-4, we still see that there is the same trend that placebo responses are really dictating some of the effect sizes that we see with respect to responses in this trial. The post-hoc analysis that was reported in the last ACR looked at composite data on rash and arthritis, combining data from both Tulip-1 and Tulip-2. And what we see is that the rash data looks pretty good because there was a stable response to placebo that was somewhat low, and a decent increase in response which was seen with Litifilimab, be it all patients or interferon high. But when we come to arthritis, the response rates really are being, again, dictated a lot by what's happening with the placebo group because of this high response rate that we're seeing. And this was true regardless of how rash and arthritis was looked at in this population, be it BILAG definition, class C definition, or swollen and tender point definitions. Moving on to the last question of this talk, which of these drugs have had promise in SLE? I guess I guess we'll just do a raise of hands for this one. Ibertamide, anybody? Teletaciocept, baricitinib, Dapirolizumab, and IL2 Restoration. So nobody thinks any of these drugs are any good. Okay, well, maybe not. Maybe you just don't have enough data. So, in interest of time, I'm only going to focus on the box that is red. There is some data on the blue box. We can talk about it later. But moving on to really the 5 drugs that I want to highlight today. Teletaciocept is a recombinant fusion protein that targets by blocking BLyS and APRIL, and it has been approved in China to treat lupus. It has been fast-tracked in the US for drug development by the FDA, and it's really looking at this very beautiful data that came out of China, where patients, regardless of the dose of Teletaciocept, seem to respond really well compared to placebo, with response rates of 68 to 76%, which is almost unheard of in lupus trials. These patients, about 75% of the patients who were on the drug had a greater than 4-point reduction in their SLE scores compared to 30% of placebo. And rate of infection was really quite well equally divided between all 4 groups. Most of the common side effects that these patients had were respiratory tract infections and injection site reactions. There were about 11 pregnancies that happened in this group. 10 of them were terminated, and there was 1 live birth. Moving on to IL2 restoration. So we all know that IL2 is deficient in lupus patients, be it that there is decreased IL2 responsiveness or because of high CD25, IL6, IL23 levels, which drive down IL2, or just the way the IL2 receptor is regulated. IL2 works by binding to the IL2 receptor through either a high affinity or an intermediate affinity conformation. And high doses of IL2 when given to patients tends to increase the expression of both Tregs as well as conventional T cells, whereas low dose IL2 preferentially works to increase the expression of Tregs. And thereby promoting some of its immunosuppressive functions and restoring the immunological balance. So again, data from China, but after the initial data that had a pretty good, again, 90% response of SRI in patients, that study did not have a control group. So they did a conventional trial of 60 patients, 30 receiving the drug and 30 placebo. IL2 was given at a dose of 1 million international units, subcutaneous injection every other day for 2 weeks, followed by a 2-week rest period. Treatment was for about 12 weeks and a 12-week follow-up phase. So while they didn't meet that SRI-4 response at week 12, they did meet it at week 24. And half the population had lupus nephritis, and they saw a complete remission in patients at week 12, higher in the IL2 restoration group compared to the placebo group, and that was sustained to week 24. Also, improvements were reported in SLE scores as well as with the ability to taper steroids. What was interesting in this trial was also that the rate of infection was halved with being on IL2 therapy compared to being on placebo, while there was at least 30% injection site reactions with IL2 in this study. Also interesting was the fact that patients who had alopecia from their lupus tended to have improvement in their alopecia with this drug. Moving on to Ibertamide, this is a high affinity cereblon ligand that leads to ubiquitination and proteasomal degradation of Ikaros and Ilose, leading to downstream effects where it reduces B cells, reduces interferon, and increases IL2. This is hot off the press data from the New England Journal of Medicine that came out this week, looking at the sustained efficacy and safety of Ibertamide to week 52, looking at SRI-4 response. Really, the drug did best at 0.45 milligram dose, with an adjusted difference of 19% between placebo and the highest dose of the drug. And this difference was further exaggerated when looking at certain subsets of population, either with high ALOS or high type 1 interferon gene signature. There was another abstract looking particularly in skin disease and found, again, that the 0.45 milligram dose was beneficial compared to placebo, particularly in patients with subacute cutaneous and chronic cutaneous disease. There was also some very interesting biomarker studies that came out of this paper that also needs some careful attention. So BIIB 059, this is, has a name now, Litifilimab, and it works by 2 ways. One is the FC-dependent way by blocking CD32, and an independent way where it internalizes BDCA2 and blocks TLR7 and TLR9. Phase 2 data was looked at both in lupus and in cutaneous lupus and met its primary and secondary endpoints with improvement in SRI4, CLASI, as well as independently in the skin disease. My last mention is that of anti-CD19 CAR-T therapy. CAR-T therapy is chimeric antigen receptor therapy that really works by having an antigen binding site and a signaling cytoplasmic domain, and it really targets individual cells. If you look at this particular cartoon, the anti-CD19 CAR-T cells binds to this receptor on B cell, releasing cytoplasmic granules that causes B cell degradation. Some of the reported side effects are that of cytokine release syndrome, seen in about 70% of the patients, neurotoxicity, and cytopenias. This was an N of 1 study that was published in the New England Journal looking at this 20-year-old with severe refractory disease. A patient was primed with fludarabine 3 doses and cyclophosphamide, and then given CAR-T therapy at 1.1 million cells. What we see here is that as the CAR-T cells increased in population, there was a drop in the B cell population, and in the subsequent weeks, what we see is a reduction in anti-double-strand DNA, normalization of complements, an improvement in proteinuria, and clinical remission that followed some of the serological markers with an improved Selena-Slade score. This patient did not have any adverse effects, but how this plays out in the real world, who is really a good patient for this trial, and whether this is going to be sustained remains to be seen in further studies. So with that, I'll leave you with some takeaway points. We need to continue to promote adherence to hydroxychloroquine, need more data to assess for belimumab safety in pregnancy. Anifrolumab works for lupus and skin disease, perhaps for arthritis, and maybe a third, fourth line therapy to use in patients. And finally, several new drugs are on the horizon. Phase 3 results are awaited. Finding the right drug for the right patient with the right trial outcomes is what is key to the success of future studies. Thank you.
All right, thank you very much, Dr. Narain. I think the questions we have are sort of, I think, something that maybe let's come back to at the end in the discussion, because I think they'd like to hear all the panelists weigh in. So thank you very much, Dr. Narain. We'll bring you back up right after Dr. Lipsky's talk.